Si. Tak tahu ni siapa ni tinggal lagi. Kita suara dekat air tawar. Dia dapat. Biasa yang awal ni mana? Kali dia mari tu kita ikut dia satu-satu lah kan. Mungkin pengalaman biasa nak lambat. Tapi kita start je lah kan. Ini pun kau tak nak cakap tak apa. Dia tak start cakap lah. Lepas tu hot next CMA tu Bul. Siapa ni? Tak tahu lagi. Tadi ada cakap dia macam ni. Lepas tu kalau macam nak invite next tu tengok siapa. Sampai hari Ilami datang dah tulis tahu awal. Dia tak boleh. Apa line? Tak ada line eh? Audi. Ada suara. Jadi kan.
Korang.
Saya baca cakap English ni tak payah ke yang tu kan. Kasi lagi tak air. Tapi dalam poskar ni mandi tak? Tapi dia mahal kalau baca doktor mana. Kenapa dia tak sibuk? Dia lagi hilang malam. Kalau dia mana saya mahu awal kan. Saya tak nak menyampaikan. Saya tak tahu. Saya tak tahu. Iya kak, iya itu. Kalau tiap hari ini ya. Boleh apa itu? Iya.
Halo, testing tiga suara 1 1 2 1 2 3. tes. Testing 1 2 3 alat tes.
Slide baru. Slide ni sekejap Lagi sikit je. Boleh. Mana saya punya ni tadi? Boleh? Ke saya bagi email kat awak ke?
Ada
Boleh.
pendek.
Tak ada, saya ada email.
Boleh hantar kat email Cme tu.
Tak share untuk
Stop.
untuk apa? Bukan.
Okay.
Oh, boleh ikut, tak ada jumpa ikut tak boleh. Budak buat nanti dah simpan.
So dia pun normal sebab
Kan?
kecil lah.
Towards the elimination of
Mereka memastikan
ada saya anak ni. Apa slide ada? Apa slide?
Tutup.
Dapat saya jadi lagi.
Yes. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. A very good morning to our honorable guests, Dr. Nurhana binti Mohamad Fazil, Deputy Medical Director 3, Head of Department, Specialists, Medical Officers, Nurses and the rest of respected Hrpz Ii staff. First and foremost, I would like to thank everyone for allocating your time attending our CME session. I am Dr. Syuhada from O&G Department, will be your MC today. Without further ado, I would like to invite Dr. Mohamad Nurfadli bin Senin, Gynae-Oncology Specialist, to present today's CME with the topic Towards the Elimination of Cervical Cancer in Malaysia. Please welcome.
Terima kasih. Terima kasih MC kita, Dr. Syuhada. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, selamat sejahtera saya ucapkan kepada semua. Saya Mohamad Nurfadli bin Senin, salah seorang pakar daripada Jabatan Obstetrik and Ginekologi. Pada pagi ini ingin bercakap mengenai tajuk yang saya kira penting untuk kita, yang bertajuk Towards the Elimination of Cervical Cancer in Malaysia. So izinkan saya present dalam bahasa Inggeris yang campur-campur lah. So when we look at our National Cancer Registry Report year 2017 to 2021, cervical cancer is no longer in the 10 most common cancers in our country. It used to be ranked at number 9 from the year 2012 to 2016 Okay, so now it has been replaced by a corpus luteal or endometrial cancer, and followed by the ovarian cancer. So, but when we look at gender specific, okay, the incidence rate for cervical cancer has also dropped from 6.2 to 6.0 per 100,000 population. Okay, so if you can look at the graph or the picture, so cervical cancer is the only cancer that has shown a marked reduction in the incidence rate. So if you were asked, okay, for Malaysian women, what is your lifetime risk to get cervical cancer? So the answer based on the report is 1 in 154 for all women. Okay, so this registry will be out every 5 years. So I believe one is due for next year or the year after that. Okay, so now come back to HRPZ. So I came here last year in January, and from January last year until May 2026, we have managed to perform a total number of 132 outpatient colposcopy examinations, and we have received 87 new referrals to our clinic. So this number doesn't include those patients who are being referred to general gynae clinic, and then they further work up and then referred to our unit, because that will fall under general gynae census. So when we look at the total number of new cancer patients for cervical cancer, 24 out of 147 new cases were diagnosed during this 17 months period. It counts about 16%. And it's interesting to note that uterine cancer and ovarian cancer in Kota Baru have similar number, because we know that endometrial cancer is most of it due to obesity, right? So kira orang Kelantan mungkin banyak kurus-kurus kot. Anyway, so but if you are in city and urban area, so basically endometrial usually will, sorry, the pointer. So usually we see more endometrial cancer now, okay, rather than ovarian cancer. So, So coming back to cervical cancer, out of these 24 new patients, okay, 1/3, about 29%, diagnosed as stage 1. Okay, and for stage 1 disease, it will further divided into stage 1A and 1B. 3 patients diagnosed with stage 1B3, and this patient were not suitable for surgical intervention. So for stage 1B3 and above, stage 2 and stage 3, we referred to oncologists for concurrent chemoradiation therapy, which has a good outcome. And for stage 4 patients, so if they are fit enough, we usually offer them palliative chemo. And for Dr. Nafal, he sometimes, there are selected cases, he still offer radiation therapy for local disease control. And unfortunately, we can't afford immunotherapy because it's way too expensive for those patients in stage 4 or recurrent disease. So that's why it's important, okay, for us to detect early on or even prevent cervical cancer from happening. So now let's look at the surgical procedures that have been performed. So we actually, Gynae-Oncology unit is a small unit. So I lead the unit, and I have one specialist who do rotations every 3 to 6 months, and I have 2 other MOs on rotational basis. So for the past 17 months, we have performed a total number of 110 surgeries, and 60% of the cases are oncology cases. The other 4 include difficult benign gynae or precancerous lesion diagnosis, or macam suspected tumor tapi turn out to be benign lah. Okay, and these are all the elective cases. Okay, for emergency cases like ruptured tumor, bleeding tumor, sometimes it's not in this data, and sometimes my fellow colleague also can perform that surgery. Okay, so now we focus on cervical cancer. So I only managed to do 6 radical hysterectomy. So it's very, I would say, low, which is good. But so when I first after I finished my training in 2023, I was placed in IKN, Putrajaya and HTA. So I performed, I think more than almost 20. So I came here, it's like very low, low, which is good, not a bad thing. So out of the 6 cases, okay, 2 cases were upstaged because of micrometastasis. So in micrometastasis, we cannot detect it through our standard CT imaging. So one micromets to the lymph node, we upstage her to stage 3, and one micromets to vaginal tissue. So we upstage to stage 2. So the thing is about cervical cancer treatment. The preferable treatment would be one or single best modality. So usually if we think that patient would require radiotherapy, we wouldn't go for surgery, because we know that radical hysterectomy is a complex procedure. It's complex, difficult. It takes more than 4 hours to perform one, and then it's associated with morbidity as well, like bladder dysfunction, okay, and few other things, urethral injury, okay, etc. So now coming back to cervical cancer elimination, okay, so is it really possible? The answer is yes. Why? Because we know that this cancer is caused by the virus, HPV virus. Okay, so in 2020, which is 6 years ago, in October, WHO has released a campaign or a strategy, plans to combat this public health disease. So the aim is by 2030, we could eliminate cervical cancer. So can it be really like totally gone? So the answer is cannot lah. Why? Because even though about 99% of cervical cancer is caused by HPV virus, you have still like less than 1% that's due to macam nasib tak baik lah. And we have one patient in our ward. She's very young, 33 years old, poorly differentiated squamous carcinoma. So, and P16 is negative. So basically when you see at the IHC, you look at P16. So if P16 is negative, it's usually non-HPV related. So, macam kesian jugalah, kan? So to achieve elimination, so one country must be able to reach and maintain an incidence rate of below 4 per 100,000 women. Okay, one of the countries that has declared they are free from cervical cancer is Australia. Okay, now how do you want to achieve this? By 3 main pillars. These are the pillars that being advocated by the WHO. One, we would prevent, screen, and treat. Okay, so if you look here, this is the latest guideline, which just recently published in May. Okay, on how to treat, how to screen and treat pre-cervical lesions. But I think this one, macam I don't want to go into this because it's new, and I think kita mungkin rasa macam sebab dia treat HPV infection. Even HPV, if you have HPV 16, you go for treatment. So kita nanti I'll cerita lah along the way, I'll cerita macam mana kita punya treatment process dekat Malaysia. So how's Malaysia doing? So I would proudly say that we are not bad. We are quite progressive actually. So we have our own CPG. This one was released in 2019, and I think it's due for revision. We also have our latest cancer survival screening program guideline, which was recently published 3 years ago. And in what we call macam dengan untuk menyambut seruan WHO, kita in alignment of WHO initiative. Masa tu Datuk Khairy Jamaluddin kan, dia kan very progressive kan. Few months after that, okay, we come up with our action plan as well to cater to our local need and our local infrastructures and things like that. So we also aim to eliminate cervical cancer by the year 2030. Okay, so now this is the magic number 90, 70, 90. Okay, so to eliminate this cancer, okay, so we need first to prevent. So the aim is 90% of our girls before the age of 15 should be vaccinated by HPV vaccine, okay? And this is, I think, the most challenging part, okay? Screening part, okay? So this screening part usually done by our klinik kesihatan, our family doctors, diorang yang memainkan peranan penting. So for women, they need at least twice, okay, 2 times, okay, screening test, okay, by the age of 35, and another one 10 years after that by the age of 45. So the test must be I have to highlight it, high performance test, okay, because now dekat lab luar sana there are hundreds of HPV tests, and according to WHO guideline, only 20 validated tests sebenarnya. So the rest tu macam diorang macam copy ori, so tak boleh, okay. So now, okay, this one is quite easy. So to achieve this, sebab kita, saya rasa lah, in Semenanjung Malaysia, because kita tak ada logistik sangat, Sabah Sarawak is different. So for 90% of women identified with cervical disease, okay, be it CIN or be it cancer, need to be treated, okay. Okay, moving on. Okay, so orang kata tak kenal maka tak cinta. So let's get to know our HPV. So what is our lifetime, okay, not like our, macam orang, I mean like, what is the lifetime risk for a woman to have HPV infection? So it's 80%. It's actually quite high and it's quite common. So you don't have to be worried about it, okay? Because we know that this virus stays in the epithelium. It doesn't get into your system. I mean, it doesn't get into your blood. It doesn't cause viremia. So it's okay. Nothing to be worried, nothing to be ashamed of, okay? Because we know that the transmission is skin to skin, okay? You don't need to have a penetrative sex, okay, to get this virus. And we know that now 12 oncogenic types, and within these 12 types, 16 and 18 are the ones that cause more cervical cancer. So this virus was discovered in 1983 for 16 and 1984. Masa saya lahir 84, so sekarang dah 42 tahun dah. So that's why WHO macam bersungguh-sungguh untuk eliminate this condition, because it has been around. We've known the case, the what we call that, sebabnya tu dah lama dah, okay. And in Malaysia, the incidence of HPV infection among healthy women is reported about 7%. So it's okay. It's not that high. It's okay. Okay. So this one is based on the new or the latest guideline yang saya cakap WHO tu. So HPV ni sekarang is further subgroup or divided into 4 categories lah. Group 1A, 1B, 1C and 1D. So then 1A, B, C ni yang kita paling risau kalau orang tu ada HPV 16. Because if you look at the percentage attributable fraction, is as high as 62.4%. So basically, yang macam mana dapat 62 ni is some statistical or mathematical calculation, okay, from the percentage of HPV prevalence in people with cervical cancer. So tadi kan saya, tadi kan saya cakap 70%. So if you can see here, when you add up, yes, you can reach about 70% of the causes for HPV of cervical cancer. Okay, so yeah, so yang ini 1D ni yang paling rendah lah, even less than 1%. Okay. Okay, so macam mana boleh berlaku infection? So basically, there are 2 main process. The first one, viral entry, is so they enter when we have they enter through microscopic test or microabrasion and cellular hijacking. So when this virus invades or get into our cytoplasm. So this one is genomic structure. So a few things that we need untuk, sebab saya macam a bit detail because ada trainee datang. So yang ni yang penting lah yang kalau kita nak tahu. So these proteins, we have E, L and LCR. So you need to know E stands for early or non-structural protein, and we have L, okay, for late or structural protein. So E1, E2 responsible for replication. E6 and E7, these are the bad ones. oncoprotein. So what it means, so basically it will suppress the action of our P53 and ribosomal protein that regulates, okay, kita punya cell growth. So kalau kita banyak sangat E6 and C7 ni, that's why it becomes the cell will proliferate and it will become tumor. Tak ada orang nak stopkan dia. Okay, so these two are bad ones. L1 nanti saya cerita. So, tak nampak. So tapi basically they start from basal stem cells, okay, starts from below, and we know that these basal cells quite ada macam stem cell kan, nanti dia akan divide and akan mature, goes up, and then dia akan integrate dalam sel ni lah. So sampai atas nanti dia akan release dia punya viral particles tu. Okay. Oh, dia ada ni, sorry. So infection, basal. So this one, the integration. Episomal means basically it stays in the cytoplasm tu. Dia tak integrate lagi dengan cell host punya DNA. Okay, tapi bila dia dah start integrate, nanti dia akan replicate. Okay, yang E6, E7 ni lah yang kita kata yang jahatnya. Okay. So now let's look at the timeline and natural history of cervical pre-cancer and cancer development. So why we need to understand this? Because if we understand this, then we know the rationale kenapa kita screen at the age of 30 for HPV, why we screen at the age of 25 for smear cytology. So we know that the peak of infection when, okay, the first sexual debut lah. So by the age of 20, kalau kita tengok sini, so these are the 3 shades of orange. Okay, the lighter one is the HPV infection. So we know that the peak would be nearing 18 to 20 years old, and it will slowly regress. Okay, and pre-cancer lesion, because it takes time for the infection, okay, to cause cellular changes. Okay, it takes at least 2 years. Okay, dia tak cepat sangat. So by the age of 30, you can see this is the time when the peak for pre-cancer or CIN lesions can be detected. And as for cancer, you can see it's slow rise lah. So macam memang tak banyak pun sebenarnya. So kalau ikut low income countries, the risk of someone to get cervical cancer is only 2% sebenarnya. Tapi the treatment for cervical cancer is so expensive, we think that the prevention is still better than cure. Okay? Sebab kalau radiotherapy tu, CCRT tu, kalau kita kat private, it can reach up to 70,000. It's just that we are in government, we order like okay lah, tak apa, but it's really expensive. 25 days of fraction followed by brachytherapy 3 times. Brachytherapy alone it will cost you about 25,000. Okay, so it's very expensive. Okay, so now another schematic, maksudnya diagram. So initial exposure, like I said, about 90% clearance infection, 70% regression, and only ni kalau kita tengok CIN1, so dia start dengan basal membrane kan, so 1/3, 2/3, and the whole thickness, and cancer is breach the basal membrane and into the stroma. Okay. So now this one dalam kita punya guideline. So it will take up to 10 to 15 years. So kita memang ada masa untuk screen and treat pre-cancerous lesion. Okay. So I hope I've convinced you all. Infection, so infection, clearance, low grade, abnormality. Okay. So akan jadi high grade, daripada high grade baru jadi cancer. So kalau tengok the shape is very pale kan, meaning to say it's very rare for low grade to jump straight into cancer. Okay. So yang pekat ni, ni lebih common lah. Memang common dapat infection macam saya cakap tadi, lifetime risk about 80%, and most of the time it will clear by itself. Okay. So this is the appearance. So normal cervix. So we need for primary prevention HPV vaccines. Okay. So kita kena screen. Bila screen ada CIN2, 1, 2, 3 we need to treat. ICC lagi lah, yang ni dah cancer dah, so treatment dia lain pula. Okay, so HPV vaccine, mechanism of action. So basically, we need these neutralizing antibodies, okay, to make sure to prevent the cell get infected by the virus. So how to do that? Okay, so we can see here, L1, this is the major capsid protein. So this protein basically, so the HPV vaccine is designed to mimic the HPV structure, okay, without having all these genomic components. So dia bukanlah macam orang kata live attenuated ke, kan vaksin kan ada banyak-banyak kan type. So this type kita panggil VLP, vaccine like protein. Okay, vaccine like particle, sorry. So that's why. So this, ingat gambar ni, senang je, E1, E2, E6, E7, dia ada, E3 tak ada tau. Nanti kalau dalam exam jawab E3 memang tak ada E3 lah. Lepas tu L1, tu je yang kena ingat. Okay, so bila kita bagi vaksin, so banyaklah neutralizing antibodies ni. Because we know that this virus doesn't go into our bloodstream kan. So our body takes time to react. So kalau kita dah inject vaksin, kita dah ada antibody, kalau ada infection, cepat sikit kita boleh eradicate or eliminate the viral infection. Okay. So does vaccine really works? Of course. So kalau kita tengok kat sini, this is a landmark study for meta-analysis published in Lancet 2019. So I think they look into more than 600,000 people kan meta-analysis kan. So memang dia tengok macam after 5 to 9 years post implementation, we can see a marked reduction in the number of viral infection in young girls, okay. And also cross protection, meaning to say, so usually at masa tu dia dapat 16 and 18 kan. So by even giving with just by 16 and 18, other cross protection, other type of subtype also get protected, okay. And then anogenital warts, okay, physical manifestation also markedly reduced. This one, what is HPV 16 and 11? Sorry, 11 and, alamak, kejap, nervous kan, 6 and 11 if I'm not mistaken, okay. And the other one, precancerization, also marked reduction, because you know that they just give the vaccine. So this 51 is actually quite remarkable because, like I said, it takes years kan before CIN2 to develop. So even then, even after 5 to 9 years post implementation, the reduction in CIN number has markedly reduced. So this one is from Malaysia. So it was published in 2022, but this is an numbered lah, macam non-powered punya data collection, but okay, they analyzed 1,000 people, okay, about almost 300 below the age of 24. So in Malaysia, we started to give the vaccine in 2010. Okay, so when they look at the incidence, okay, the prevalence, so we can see there's a marked reduction, about 90%. Okay, for this lady, so lady ni actually masa 2013, dia orang tak dapat lah vaksin. So nak katanya kalau kita tak bagi vaksin, so kita tengok the prevalence is 1.7. Like I said, kan dia akan menurunkan dia punya prevalence. So it shows that if we don't do anything, the prevalence is about the same. Okay, similar as this one. Okay. So when is the best time, okay, to give HPV vaccine? So this author, so he did a study, okay. So kita memang tahu kalau you bagi vaksin, you boleh bagi je, tak kisah sebenarnya. Tapi when is the best time? So it shows that the best time to give is before the age of 17. Why? If we look here, if we manage to give the patients, but from this paper, if we manage to vaccinate, okay, school girls, which is before they leave the school, right, we have a 88% lower risk. So the protection is about, the incident rate ratio is 0.12. So the lower the incidence rate ratio means greater protection against cancer. So that's why you need to understand why WHO set the age by the age of 15. So the good thing about school children, kita memang boleh tangkap dia. Dia memang datang sekolah. Sebab masa tu, at that point of time, they give 2, sorry. pula. Sorry. Masa tu kita masih bagi 2 hingga 3 doses. That's why kalau you datang sekolah, you don't miss the vaccination. So coming back to Malaysia. So 2006 HPV vaccination first launched globally. So 4 tahun after that, Malaysia established National HPV Vaccination Program. Meaning to say within these 4 years, kita tak ada vaksin ke? Kita ada, tapi kena beli sendiri. 4 tahun after that, it's free for every registered school children. Tak kisah you are from private or whether you are from government, cumanya sekolah you kena berdaftar lah. That's why there's some concern in schools yang macam private school yang tak berdaftar kan, sebab benda-benda macam lah in terms of vaccination and things, they might miss it out. Okay, so the types of vaccination available, 66, so we have bivalent, meaning 16 and 18. Kalau dekat kita jenama Cervarix. Okay, quadrivalent, 16, 11, 16 and 18. So 16, 11 is anogenital ward protection. This one is dulu ada Gardasil 4 lah. Sekarang tak ada dah. So now they have added another 5 more strains. Okay, this one masih dalam 1C lah kalau subgroup tadi kan. So this one is 1A, this one and this one is 1B and the rest 1C group. Okay, so let's look at our national HPV vaccination program. So it started in 2010. They give either bivalent or quadrivalent vaccine. Sebab masa tu macam tak boleh lah satu company je yang menangkan dia kan. So macam separuh-separuh. Okay, the targets were 13 years old, birth cohort from 1997. Okay, however, we have catch-up efforts actually. So catch-up efforts ni basically orang-orang yang terlepas lah, yang 6 years behind. Kalau diorang masa ni masih yang ada bersekolah ataupun yang baru saja habis sekolah. Pada mereka yang masa tu yang baru saja habis sekolah, they can get free vaccination dekat LPPKN. Masa tu diorang memang promote HPV vaccination free dekat LPPKN. So it's just masa tu it's not exclusively for school children. I think masa tu diorang kata up until 21 years old untuk free vaccination boleh ambil kat LPPKN. Tapi kita punya coverage 80% je, more than 80%. Kita tak dapat reach that 90% vaccination. Sebab apa? Ni semua sebab gara-gara COVID. Okay? So if you look before COVID era, the rate is more than 90%. Easily achieve that. However, because the pandemic, we tak ada stock. Masa tu semua orang buat vaksin COVID. Lagi untung. That's the more, I think that's the more urgent kind of vaccine. And actually kita punya MOH ni memang sangat progresif. Bulan Ogos kita dah buat meeting sebab the procurement masa tu dah tamat dah. Lepas tu kita memang tak ada stock. Lepas tu Gardasil 9 keluar. Bila Gardasil 9 keluar, dia stop Gardasil 4. Dia kata tak nak jual Gardasil 4 dah. So it incurred, see the price escalated by 600%. Okay, ni Gardasil vaksin ni yang Gardasil 4 yang biasa lah pun naik juga 3.7 fold. So because of this, there's a massive backlog of unvaccinated schoolgirls from the pandemic cohorts, rendering the traditional multi-dose procurement strategy unsustainable. So maksudnya what to do? Then barulah WHO keluarkan statement. So I'm trying to say that actually kita quite progressive. A few months after that, then WHO keluarkan statement. So when WHO came up with a statement, so they changed the recommendation dose from 2 doses down to 1 dose only. Okay. So by the time 2025, 67 out of 144 member states have successfully adopted a single dose strategy. Masa ni low income and middle income countries memang tak dapat vaksin because America, UK semua diorang monopoli sebab diorang ada duit, diorang kata diorang punya vaksin tu diorang nak. Sebab I think US still practice 2 and 3 doses of vaccination. They still haven't changed. So Selamat ke? Betul ke? Boleh ke? Actually, there are studies. So if you look at the countries like Kenya, Tanzania, India, Costa Rica, all these like middle income, low income countries, they have done the study. It's actually, if you give it early, okay, you can get similar protection. So there should be no worries. So this one, Kenshi, is I think is a landmark study actually. Okay, so it shows a good effect of single dose vaccination. So the good thing about single dose, if it delivered early, it can show high levels of protection, similar in magnitude to multi-dose regimes. Okay, so this one is exclusively for people less than 15 years old. Untuk kita-kita ni yang dah bekerja ni, kita kena 3 doses lah. Okay, so single dose schedules may present significant cost savings and can help with overall delivery challenges, promote global health equity, and will help increase access and uptake, and it reach more girls with a single dose, and then rather than you vaccinate a smaller number of girls for 2 doses. Okay, now coming back to Malaysia. Okay, I dah nak habis dah ni. Okay, so the evolution. So we know, so Pap smear was first introduced in 1940. So lama dah kita punya papua apa benda tak lama, that professor yang introduce Pap smear ni. So they see cellular changes before it turns into cancer. So only about 30 years after that, Pap smear was introduced in Malaysia. Okay, and then in 1995, we have this campaign, okay, healthy lifestyle campaign. So masa tu diorang promote lah benda-benda yang boleh mengelakkan penyakit-penyakit. Salah satunya penyakit kanser. Apa nak buat? Pap smear kan? Okay, then in 1998, it's I think this one is a bolder move when we run it as a one entity. Kita tak associate dengan orang lain. Kita nak Pap smear kita je. 1998. So masa ni kita punya eligibility 20 to 60 years old. So can do Pap smear yearly for the first 2 years. Then kalau normal 3 yearly. Okay. Okay. Lepas tu in 2099, HPV DNA screening test will officially become available. Okay. Now look at the test. Okay, like I said before, conventional Pap smear. Okay, this is opportunistic screening, high clinical burden, lower sense. What does it mean by high clinical burden? Because kita kena hantar slide tu. Kita kena, patient kena datang, kita kena pakai speculum. Okay, it's quite uncomfortable. Kita kena ambil, kita kena script dekat slide, hantar makmal, pathologist, histologist kena baca. Okay, and then a better way of detecting cellular changes, we have liquid-based cytology. And then they added up this primary HPV DNA testing. So dulu dengan cytology, okay, kita order sekali HPV. Okay, now the latest one, HPV self-sampling. Tak payah dah buat speculum. Don't need pelvic examination. All you need to do is just take the swab and do it in your private room. But remember, this is screening for those patients who have symptoms. They can't do HPV self-sampling. Okay, they need to be examined. Okay. So basically, what is HPV self-sampling? So it's simple. Kita panggil swab nama dia. Okay. So it's simple. Patient administered vaginal swab requiring no speculum or clinical supervision. And it's a stable medium, okay, unlike kita punya smear tu yang kita kena fix dengan alcohol. So dry transport stable at ambient temperature, eliminating the need for cold chain laboratory transport, and it can be performed in privacy directly, mitigating cultural stigma and the discomfort of pelvic examinations, right? So based on our screening policy, for HPV, okay, so the target group is 30 to 65 years old for sexually active. So HPV test is recommended. For those who are younger than 30, cytology screening can be offered. But I think younger than that, if we do because of symptoms, we don't call it screening anymore, okay? And then if you more than 65, I think it should be okay lah. So screening intervals in terms of cytology, like I mentioned before, this according to the previous guidelines, but if you do HPV testing, you can do it every 5 years. So it's very cost effective if you think about it. Okay, so let's look at HPV screening coverage by states as year 2024. But this data is only from KKM. Okay, it doesn't include our hospital, university. Okay, that doesn't include our private clinic and clinic swasta yang lain. Unless it was referred to us, then it gets into our census. So look at Kelantan. Actually, Kelantan is not bad. Siapa kata orang, yelah, kan Kelantan kan banyak orang Melayu kan. Siapa kata orang kita, tak nak screen. Okay je sebenarnya. So basically, but it's still low, only 7.5. And HPV is actually available in our KK, at our KK. I don't think it's I think it's big KK, they have it. So it's just that kita tak utilize kan, kita tak promote kan. So if you look here, but the population here is like in Kelantan not as many as other states lah. Sebab tu masa mula-mula saya datang ni macam sunyi je klinik saya. Tapi kita badan lah sebab kita punya population not that many compared to KL, Putrajaya where I used to work. Okay, so in average, so when we average it all together, the HPV testing coverage in Malaysia is only 4.6. It's quite sad. Okay, so why is HPV testing under-recognized? Okay, despite overwhelming scientific evidence, HPV DNA uptake remains low. First, because of legacy reliance. Orang semua fikir Pap smear ni bagus. Sebab it has been long in the market lah, ataupun in the business. Okay, lack of public awareness, limited access. The thing about, so we have this Rose Foundation where they initially initiate the program of self-sampling. The problem with Rose is that the thing about screening, you must to be responsible. Okay, if you do screening, you must make sure there's a treatment if patient diagnosed or turn out to be positive. So many centers or many tempat-tempat yang macam jauh, diorang tak boleh nak pergi. So that's the limitation sebenarnya. Okay, cultural, behavioral and logistic barrier, stigma, embarrassment, health literacy and difficulty attending appointments. So I think I have one case last year, a doctor in one of our KK, she did HPV about 2 times negative, but she got these symptoms. And then I tell her, like, you got symptoms, why did you do HPV test? You should get yourself checked. So by the time that we got the HP, it's confirmed to be malignancy, and it's already stage 1B3. Okay, so even among doctors, okay, if you don't get it right, okay, you don't do it right. Macam tu lah. So remember, screening is only for those who are asymptomatic. Okay, if patient symptomatic, cakap ada berdarah luar biasa, bila bersama pun berdarah, do a speculum, look at the cervix, then you can take the swab. Okay, either you can take the Pap smear, cytology plus DNA, pun boleh. Okay, training and monitoring gaps and fragmented care pathways and follow-up systems. So this one ialah kita tak ada national data kan, registry. So that's our challenges. Okay, so let me convince you, HPV testing is actually good, okay, compared to Pap smear. So it has a high sensitivity, which means that HPV misses fewer precancerous lesions because we can detect the presence of the virus. Unlike Pap smear, kalau orang tu salah ambil tempat, tak nampak lah. Okay, and specificity, of course, Pap smear is higher, meaning to say Pap smear have fewer false positive because if you see abnormal, memang you see abnormal lah. That's why sometimes kalau kita ambil dululah, kalau ikut kita punya screening, kalau kita ambil HPV positif, kita akan ambil smear, and then sometimes biopsy untuk confirm whether any cellular changes ke tak. Because like I told you, infection doesn't equal to cellular changes. Okay, because it takes time for the cellular changes to happen. Okay, positive predictive value. Okay, of course, a positive pap smear is more likely to mean that a true lesion is present because of high specificity, like I mentioned. However, it has extremely high negative value, which is an ideal test for screening. Okay, that's why in screening we need to rule out. Kita nak make sure that our negative is true negative. Because this is not diagnostic kan. Kalau diagnostic lain, kita nak make sure that it's betul-betul positif. Okay, now. Okay, almost. So, kalau kita tak buat apa-apa, okay, let's say we have a squamous intraepithelial lesion, cytology. If it comes out, and kalau saya dapat terima ascus, ascus ke macam tu lah katanya kan. Sebab because we know the rate of progression is about 68%. Invasive is very low, less than 1%. Different from HICIL. If your pap smear reported as HICIL, you have a 1.4% of invasive. It will progress to invasive changes. So that's why sometimes masa saya train dulu, Dr. Jamil, kalau pap smear kata HICIL and we do colposcopy and we take biopsy and it's negative, dia suggest kita treat juga. Sometimes we might miss. And sometimes dia bypass colposcopy, outpatient colposcopy dah terus treat. Okay, if someone has confirmed their entry by histology, this one is cellular. This one is more macam kena berhati-hati. Their entry, you know that the progression to invasive cancer can go up to 12%. So we don't want to miss these patients. Okay. Unlike CIN1, only 1% can progress, okay, into into invasive. So basically, you have a persistent chronic infection, HPV infection, then it will lead to cervical cancer. Okay, so that's why 2 and 3 kita kena buat something. Okay, so my last 2 slides. So CIN1 management pathway, CIN2 and 3. So initial steps, and we have abnormal smear or cancerogenic HPV positive. We should do colposcopy and biopsy. This one is based on our CPG. Kita tak based dengan saya cakap yang HPV WHO 2026 ni. Kita still panggil untuk colposcopy. Okay, and we do biopsy. So for CIN1, a patient can opt either for conservative management, and usually we repeat cytology in 6 to 12 months and see whether any regression, or we can offer ablative treatment, okay, in the form of cryotherapy or thermal ablation. For CIN2 and 3, surgical treatment is required. So usually what we usually perform is LATS or cone biopsy. I would usually prefer LATS because it's less bleeding, it's easier to done, and usually patients are still young, okay, who still have desire to become pregnant. So because if we do cone biopsy, there's a risk of short cervix that could cause premature delivery if she gets pregnant. Okay, so this is how it looks like. We have this in our clinic. You know, when I came here, I was like, oh, impressive. I don't have this in KL. So this is cryotherapy. This one is a new one. This one is ablation heat therapy. So this one is more user-friendly, battery recharge, handheld, okay? And this is how LATS or LEAP looks like. We use this special device to cut the cervix, and this one is a cone. We use a knife. Okay, once again, prevent, screen, and treat 90, 70, 90. Okay, with that, thank you. Any question before I ask question? Yes, Irwan.
Any benefit that is later in life kan, macam that woman want to take another type of vaccine later in the life lah. Benefit tak? Macam mula ambil severik kan, and then later after marriage kan, H3 then ambil galaximan. Any benefit tak?
My Dr. Syarif cakap, are you really that high risk? If no, there's no need. So we know that 70% 16 and 18, and there's a cross coverage as well. So I think that because we know that even patients who have received vaccination, it doesn't preclude or exclude them from screening. Yeah. So despite of having vaccination, you still need to go, like I said, two times the screening. Okay. It doesn't negate the need for screening. That's why we still 90% okay, prevention and 70% screening. So the answer is no. But if you are a gynecologist, I would strongly recommend you to take HPV vaccine. Because when I first started my training dekat ICANN, my boss told me that masa dia train dekat Korea, it's not statistically significant because we know dekat NPC kan, HPV juga kan. So NPC HPV virus juga. So kita deal banyak sebab masa dekat IKN dengan KKL banyak CIN, and I do like in 1 month 20-30 lead tau. So macam kita buat macam lead. So asap-asap tu my boss kata you better take your vaccination. So I did take, not saying that I'm high risk, but because of the procedure. So if you haven't vaccinated yourself for young gynecologists, you better take lah, just to prevent yourself. Okay. Any question? Okay, let me ask you. My first question is very easy. Which of the following interventions represents the most effective method for the primary prevention of cervical cancer? Siapa nak angkat? Rokia. Okay, HPV vaccine. Okay, good. Okay, betul jawapan. Okay, this one's a bit tricky. Tapi I've mentioned this before. The human papilloma virus vaccine provides robust, long-lasting immunity against targeted HPV strains without carrying any risk of causing an HPV infection. Which of the following best describes the composition and mechanism of the vaccine that allows for this safety and efficacy profile? A, B, C, D. Siapa nak jawab? Angkat tangan. Fatin?
C.
Yeah, betul. VLP. With that, I thank you all, and sorry kalau salah silap. Thank you.
Thank you, Dr. Fadli, for the very good and informative presentation. With that, we have come to the end of today's CME session. I would like to invite Dr. Nurhana binti Mohamad Fazil, Deputy Medical Director 3, to deliver the certificate of appreciation to our respected today's CME presenter. Please welcome. Thank you, Doctor. With that, we have come to the end of today's CME session. The upcoming CME will be presented by Wound Unit. Thank you, everyone. Assalamualaikum warahmatullahi wabarakatuh.